Greetings and welcome to In-Depth. I'm Dike Rostant. How do we treat those of our loved ones and those in our care when they are close to their last days? We are having a conversation with a CEO of the SWRHA, Dr. Brian Amour, about work being done on the oncology and palliative care treatment at the Augustus Long Hospital. Thank you very much for having another conversation, Dr. Amour. And I want to start off asking about the facilities that deal with oncology in the SWRHA as it exists.
Okay, right now it is at the San Fernando General Hospital, particularly in a section of our hospital towards the rear of the hospital closer to Naparima Bowl. San Fernando General Hospital, it's a 700-bed plus hospital with 17 medical departments, so it's a pretty large and complex facilities for which the oncology department is but one. So that's where they are presently, where they conduct outpatient clinics, and they offer chemotherapy services for persons who need to get cancers treated through medication. And also, of course, if persons are critically ill, well, then there's warded care. So that's the current situation right now for the SWRHA.
But I know a previous time we spoke, you said that it's catering to about 600,000 people. So looking at the fact that there's so many beds, is it that you're trying to have more, or is it just that you want to spread out where people are going to? What's the rationale behind having oncology services at the Augustus Long?
For several reasons. Well, one, first of all, cancer as a health condition is becoming more common, again, as a chronic disease because of lifestyles and environment. Two, because of the growing burden of cancer in the population, we have found that the existing structure at San Fernando General Hospital, basically the services have outgrown that location right now. And also because when you look at the throughput, the amount of services, for example, the chemotherapy service alone, they see an average of about close to 9,000 encounters per year for persons who just need chemotherapy. That excludes new patients coming in the outpatient clinic, I believe about 50 per month, right? And they also have facility visits as well. They do about close to 300 chemotherapies per month as well, and they see close to 600 new patient visits per year on the basis of chemotherapy. And where they are right now, it is simply outgrown that facility. And the other thing is that as a country, the government has approved this arrangement where we have to expand for the Southland, so to speak, the access to services for oncology, similarly like how you have St. James in the north. This will be like the southern version of things.
Okay, and when it's completed, what kind of numbers are we speaking about in terms of catering? The way that you would have been able to give the those estimates or those figures for San Fernando General, what can we expect here?
Yeah, well, in terms of what we could expect here, we're doing it in phases over like about 3 to 4 years. So the first phase that's coming in a couple months, as was announced by the government, is that first of all is our waiting area. The waiting area where we have at San Fernando is small. So here we propose to do a waiting area that could house 150 persons at one point in time. So we're going to have a large outpatient clinic area. And then after that, we're also going to be in the business of offering the chemotherapy that's done at San Fernando here. Here at Augustus Long, and there are several iterations as to what the final decision would be for the country, what we'll call here. One thing we're looking at is to consider here being called the South Cancer Center of Trinidad and Tobago, to counterpart with St. James in the north. So apart from the large waiting area, we also would have areas to offer chemotherapy, and then we also would have setting up a palliative care bed service here at the facility in the first phase.
And so we hear the term. Explain or define palliative care first.
Palliative care is care for persons for which all other options of a cure or a recovery to a quality of life is not possible. So it is what some persons would call end-of-life care, or or care where there is no cure at the current state in time, and therefore that is a phase of life for everybody, and therefore that is something that requires, particularly due to cancer, a lot of sensitivities to prepare the patient and even for staff to work with the patient at that stage of life.
So you spoke of cancer as one, let's call it category, and you'll correct my narrative in my terminology if you need to, please and thanks. But when you hear that someone is going through palliative care, does that almost automatically give a kind of timeline that you're expecting?
We are not in charge of timelines for life, it's bigger than us, but it means to say that based on assessment, there is nothing else that can be done, and there are prognosis based on survival rates. So basically, depending on the stage and grade of the cancer that you're diagnosed at, and depending on the relative success of the treatment, and depending as well as what are your predisposing health conditions even before the cancer, doctors can apply science to give you an average amount of time that you are expected to continue to live with the disease. And therefore, at that point, we'll determine whether or not you are a candidate to enter the palliative care program, which means that we're taking care of end-of-life requirements, which is not only necessarily physical. A lot of times we have to manage pain, we have to manage mental health issues, persons have to deal with their estate planning, and all of that will come in the palliative care at that stage in terms of a holistic service. And of course, you have to take care of the families who are being impacted and affected as well.
And one of the reasons I ask that question is because sometimes, and this is sharing anecdotally, you hear persons, they get an expected time. Now, it seems as though when some people get an expected time to live, things can go one way or the other. Some people, as it seems as almost as though as soon as they're here, they don't last much longer. Some people defy so many odds. They talk about his outlook on life, or the way that they have possibly an attitude of gratitude. And I'm glad that you're saying there's so many factors that go into it. And I want to speak to some of those factors that you started intimating. When we return from this break, we are speaking with the CEO of the SWRHA, Dr. Brian Amour, about a raft of things as related to the Augustus Long Hospital. Stay with us. We return after this. Welcome back. We are speaking with the CEO of the Southwest Regional Health Authority, Dr. Brian Amour, looking at work being done at the Augustus Long Hospital. And speaking of palliative care, you spoke about entering the program. What are some of the things that are already established? So is it that I don't know what to do for my family member? Let me see if I can get them into this. What are the steps that one would need to take?
Well, to put it in some perspective, right now the current system that we have is still at San Fernando, and that palliative care, once somebody is deemed to be eligible for it, there's not sufficient need or sufficient architecture at Southwest at the current time. What we propose here is a future state that we are hoping on or around July or August at the earliest. We will announce to the public when it is the exact time that we'll be able to launch the service, but it will be before the end of 2024, right? That is definitely what we're aiming for. So at that point, once we launch a new service, which will be an expansion from San Fernando to here now, then there would be normal admission criteria, which would be at the level of the attending physician oncologist. So for persons who have family members that would be impacted and affected, and they think that they're eligible, they will still have to come through our system for assessment, and the assessment will be multidisciplinary. The nurse specialist doctor, we also have social workers and other persons to make a holistic assessment, because we are starting off with between an 8 to 15 bed palliative care unit, mirroring the models that they have in other regional health authorities as we launch on our own. So therefore, it will really be true referrals to see our specialists, and then our specialists will make the determination if you are fit to be admitted into that level of care.
how close do you link palliative care and oncology treatment? Because even though I take the point that they're distinct, it seems as though they're being spoken of kind of closely together.
Yeah. Oncology treatment is treatment for cancer, and cancer could either aim for a cure, you could aim to have a quality of life, hoping for a cure, in which case most cancers you look at like about up to 5 years to see if you're what to call remission. Are you cured from it? So sometimes you could get an outright cure if you catch it early, which is why we encourage screening. If it is that you're at a stage where you have to give you treatment, whether it be surgery or whether it be medication, we look to see if we could hope for a cure. And then some persons, they either present late, which is why we encourage screen early. If you present late for certain types of cancers, it is preventable. Not all cancers have a clear prevention, but the common ones do have good prevention screening strategies. But if you come late, or despite all the efforts, it is still late and you cannot aim for a cure, hope for a cure, then that is where we reach with the palliative care. Palliative care in of itself is a science because it is not only necessarily due to cancer that you could have end of life. There could be other reasons where there's nothing that could be done for a cure. So for example, if you have what we call a degenerative brain disease, and therefore you're going to lose your faculties, and there's no cure for it, that person would end up being able to not be oriented anymore to time, who they are and person, and therefore they cannot live independently anymore. And it is going to be difficult eventually for their bodily functions to manage themselves, like eating food, digestion, and swallowing. So palliative care as a science, cancer, yes, is a main reason that they could enter, but there are other diseases. So that's why even though it's linked, it's not exactly the same.
What are the facilities that exist for palliative care? And I'll ask SWRHA what exists, but also a little further afield in Trinidad and Tobago, that is.
Well, to the best of my knowledge, there are private partners that work with the RHAs and sometimes RHAs themselves. So I'm aware that there is in North Central RHA as well as Northwest RHA affiliated to St. James, that's Northwest RHA, and there's one in North Central RHA. There are a couple persons in the private sector, and we have certain doctors with certain passions with it. So sometimes palliative care in the current scheme of things could be done sometimes in private home settings, but only for those who may be able to afford that level of care. So at Southwest, we recognize it is an unmet need, and that is why, based on the approval of the government and the policy direction, Southwest has been partnered with in order to establish a palliative care unit that has an identity of its own, based on the fact that at San Fernando we don't have enough space in the current architecture for it.
You spoke of a model that cited 8 to 15 beds. It feels as though that might be a kind of sweet spot. What's some of the pros with that amount?
Well, to be honest, it was 8 beds. Up to recently, that was our initial plan. But when we really looked at it, and again we consult with the staff and we look at the demand, and plus we're trying to be ambitious to meet the needs of the population, we just made a recent decision that we would aim to go up to 15 beds at the start. And then based on the demand, and we compared with the other palliative care sites, as I said, in North Central and in Northwest, or at least housed in that jurisdiction, with the operating partners being non-governmental organization affiliates. We think for the size of our population and noticing the success there, then we would aim to start off there, and then we will take it with the population and with the staff to move forward.
In terms of just logistics, what does it mean to an individual or to their family who's trying to provide that sort of care for them to have a facility like this? And this is both in terms of responsibilities, the possibility of visiting, but what does it mean that your loved one, the person in your care, is able to be at a facility like this?
It's a good question. I think at an individual impacting level, remember, they would see their relative or loved one go through phases. Or if you're diagnosed late, you are getting a sense of realism about life in a profound way. And there is in medicine something called caregiver burnout. Taking care of someone, if you don't have enough resources or support, can be very tiring. For at a lot of levels. Psychologically, it could take an emotional toll, a financial toll. Some studies suggest to show if you don't plan for things like that, you can get a financial catastrophe because of taking care of someone. So a service like this would give not only the patient dignity, privacy, and end of life comfort, because pain sometimes is a big issue that has to be controlled for cancer with palliative care. Also helps the caregivers of the loved ones, as I said before, do things like their estate planning, wills, managing their own emotions and so forth. So it is a holistic service. So it is a lifeline for persons, and it is something that persons don't like to talk about, but where there's life, there's end of life. It's a cycle. And therefore, this is what, and it is an advanced medical science, a specialty area in its own right. So this is what we wish to offer before the end of 2024 to the people who live and work in Southwest Regional Health Authority.
And that's one of the things that's really studying, because yes, finances is one thing, but that burnout, especially when you know this person, you know them so vibrant, able to do this, able to do that. People talk about once a man and twice a child, but I think there's different qualities where you're talking about that twice a child. So really being able to be close, but have that help and that support is something that really needs to be appreciated. But this building is one that existed before. So what are some of the things that are being done? This is in terms of being created new or being retrofitted to be able to offer these services.
Great. So Augustus Long Hospital, I again wish to emphasize that this is government approved, and it was born out of, you may be aware that here was granted through the Ministry of Energy and Heritage Petroleum Limited for the use for COVID. And when we observed that level of partnership in operating here for COVID, and we know that based on the government initiatives that COVID would be, as it is now, a relative thing of our epidemic past, even though we still have to be careful and avail of vaccines, we recognize that here has potential. And again, because of the interests and the common interests, we are very happy that it's here. So what we propose to do, it is really remodel, repurpose the building. So in summary, we're going to have a large outpatient clinic waiting area, as I said before, 150 seating area, large waiting area. We are going to be able to offer the chemotherapy services in a more comfortable environment. And we're actually going to bring the associated building blocks, particularly in pharmacy, to allow for this chemotherapy service to be housed here. That's in the first phase. We also, in the first phase, are bringing in equipment, again in partnership with the Ministry of Health and the Inter-American Development Bank, in order to bring the diagnostics. What we have found, and in Southwest and throughout the country, cancer management requires us to be able to what we call grade and stage clients. If you get diagnosed with cancer, we need to know what type it is and has it spread. And therefore, you depend on diagnostic equipment, mainly radiological equipment. But to be honest, in the limited resources that we do have, when you have all other health conditions, remember San Fernando has 17 departments, 17 specialties. What you find is that you actually do need, as is best practice, like what happens in Northwest or St. James, what happens around the world, you do need a dedicated diagnostic facility. And in that light, we are also working with the Ministry of Health to bring in, at the start of the phase, initial diagnostic equipment that would help us diagnose the common ones. And then over the next 2 years, we plan to bring in more modalities of radiological diagnostics that will eventually build out this facility to like a full-fledged oncology center, as per what happens in St. James. And of course, taking lessons learned, every new facility wants to be cutting edge. So we do aim to get it to where it would be, let us say, in 2027 with cutting edge technology. So we're starting in phase 1, but we're going to go to do other things.
And we hopefully will be able to speak on these other things as they're rolled out.
Yeah,
but we
sure.
want to thank you very much, Dr. Amour, Dr. Brian Amour, CEO of the SWRHA, speaking about some of the things that can be expected, hopefully in the short term, in the Southland, looking at the Augustus Long Hospital. And on behalf of the entire TTT team, this has been In Depth with me, Dike Rostant. Thank you so much for joining us.